Hello and welcome to the Menopause and Cancer podcast, where we speak with cancer patient survivors and incredible experts in their fields to help us find solutions to our symptoms and ideas to improve our health. I'm your host, Dani Binnington, and today's episode is one that if you had told me a year ago, I would have said, that's never going to happen. Because we're talking about something I was told over and over again wouldn't be possible in at least our generation, a new clinical trial exploring the use of HRT for breast cancer patients. And now it's happening. It's a huge privilege to be on this journey and to report back really about the insights of clinicians and survivors who are navigating menopause after cancer for over 200 Wednesdays in a row. And so I'm always excited to bring you the latest evidence and the latest things that are happening out there. In today's episode, I'm joined by Dr. Sarah Glynne, who is a GP and a menopause specialist. She has worked so hard for years to get this paper off the ground, not alone, but with a huge team of people supporting her. And one of those people is also joining us today, Professor Vaidya. He's a consultant breast surgeon and a researcher, and another author of the paper. The paper we're talking about is called Menopausal Hormone Therapy for breast cancer patients. What is the current evidence? And together with these two amazing people, we're going to unpack what the paper actually means, what it tells us about current evidence. I want to understand what's different about this paper, especially as when they released and published the paper, there wasn't any new evidence. So what's different about this paper? And what does it mean going forward with this new trial being initiated? I want to understand who can participate, what the doctors do with this information, what the survivors do who are already on hormone replacement therapy after a breast cancer diagnosis. And there was so much to unpack. I made it into a two-part conversation. So next week, I'll be joined by Dr. Sarah Glynne again, and we're going to talk a little bit more about the intricacies of testosterone after breast cancer. There was just too much to pack into this one conversation. It's a huge privilege, and actually some of the insights from Dr. Vaidya have really blown my mind. The way he explained some of other trials that have been done for breast cancer patients, for new ways of surgery and for new medications, and how he relates that to this new trial for HRT after breast cancer really blew my mind, and it really opened my horizon and allowed me to think about it all in a very different way to even an hour ago before I went on that call with them both. So I'm going to link to everything in the show notes, to the trial, to the paper, to everything. If you want to know more about some of the studies these two experts will talk to us about, please look back. I've got a great YouTube series on HRT after breast cancer, and I do talk about it all in my book, Navigating Menopause After Cancer as well. There is a huge chapter in there, and I explain to you about all of the studies and what they mean. So without further ado, let's bring Dr. Sarah Glynne and Professor Vaidya onto this call. Thank you both so much for being here. How are you today?
Fine.
Sarah, hello. Professor Vaidya, hello.
Hi. We're very well, thank you.
I'd love to discuss your recent paper and the very, very many hours and years of hard work that have gone into it. Can we start a little bit with why did this project come about, Sarah? If you don't mind, we start with you. I remember sitting on a Zoom meeting many years ago where you discussed your ideas of doing a little bit more research about it. And it's incredible you've pulled it off. Well done. Take us back 2 years ago.
It started because as I was becoming more involved in menopause care and focusing purely on menopause, I found that breast cancer was always the elephant in the room. And I was always talking about breast cancer. And initially, it was just something I needed to know more about. And I also recall very early on, Sarah Ball, who I think you also know. So she had done a really interesting audit looking at the women's experience of menopause care after after breast cancer. And I remember she presented this data at the EMAS conference, at the European Menopause and Andropause Society conference 2 or 3 years ago now. And I remember being quite shocked at the time at the sorts of comments that women were leaving about their experience of menopause after breast cancer. And although, as we'll talk about, I'm sure, lots of women get on very well after breast cancer and lots of women don't experience side effects, but equally there are a large number of women who do experience side effects. And for many women, the side effects, I've heard women say, can be worse than the breast cancer treatment. And we hear things like women feeling broken and abandoned and not listened to and not helped or supported through their menopause experience after breast cancer, because of this perception that HRT, which is the most effective treatment for menopause symptoms, cannot be used after breast cancer diagnosis. So it sort of started from there, and we wanted to, initially we wanted to do something called a Delphi process, which is where we had a group of experts in the room. 18 were doctors, so either menopause specialists or gynecologists or breast surgeons. There was a radiologist, and we had some patient representatives, and you very kindly agreed to participate in those early stages as well. So this was the meeting that we had sort of early 2022, I think it was, so almost 4 years ago now. It's extraordinary. And we used this thing called the Delphi methodology, where we wanted to review the data, and we wanted to, because there are huge evidence gaps, we wanted to use expert opinion to bridge knowledge gaps and come up with a set of statements or recommendations to try and improve menopause care for women after breast cancer, and specifically the role of HRT after different types of breast cancer. So we did that, and that was finished in around about, I think it was 2023 or something. And I remember I wrote an early draft of the paper, probably 2 or 3 early drafts of the paper. And around that time, I was introduced to Professor Vaidya, who very kindly, probably did not realize what he was getting himself into at the time, but very kindly said that he would look at what I'd written. And it started, I'll let Professor Vaidya carry on here, but it started very slowly. And I remember at one point saying to Professor Vaidya, maybe you'd like to be a co-author on this paper, and I think it sort of snowballed from there, and the evidence review got bigger and bigger and more comprehensive, and we've ended up with this paper that's a dual methodology, the Delphi consensus, and a big narrative review of all the available evidence looking at different types of hormones, different types of breast cancer, and that's what's just been published last month.
Amazing. Professor Vaidya, would you be able to tell us a little bit about what you do for work and why, when Sarah presented you with her work then, you thought, oh, I'm interested in this and I'd like to help push this forward?
Well, I'm a professor of surgery and oncology at University College London. I'm also the incoming president of British Association of Surgical Oncology. And I have for last 20, 30 years faced this problem of women with menopausal symptoms and having had breast cancer. So my specialty is breast cancer, and it is not just operating on patients' breast cancer. I look after them, I believe, on a whole. And they would say, well, actually, nobody asked me this question before about menopausal symptoms, and nobody was bothered to listen to what we're saying. And I found that odd. So, and I thought we must do something about this. And when Sarah came along and she sent me the first draft, I said, well, this is brilliant. This is going to be very important. And I think I knew what I was getting into from the outset. So I expected this to take some time, but I thought it was really important to do that, because what I didn't want to happen was, on one hand, there was at that point a lot of campaigning to say, oh, everybody should get HRT, because it was not just about breast cancer, it was about just any HRT for anybody. And that the ban on HRT I've done studies on how HRT use reduced in Scotland, for example, after a study was done about 10 years ago, 10, 15 years ago. And then slowly people started realizing that actually it's okay to take HRT. This is people without breast cancer. And it made a big difference to many women. Not everybody gets a menopausal symptom, but those who do, it can be troublesome. So therefore, the tide was turning into accepting HRT as an option for people without breast cancer. And certainly guidelines changed and into saying, well, actually, it should not be a blanket no to taking HRT. It should not be scaring women to say, you'll get breast cancer if you get HRT. It should be a joint decision. And then why not for patients with breast cancer? And then we realized as I started working with Sarah that the evidence is scarce. And so the Delphi consensus, we have to know it is very good that we had it done, but it is after all a compromise because it is based on people's thoughts and feelings and so on and so forth. Of course, those are very, very important. But when we're making scientific decisions about it, we try and have evidence. That's how breast cancer has been sort of epitome of evidence-based medicine. And we found that that is lacking. In order to establish what is known, what is needed to know, that took 3 years to write the paper. And thankfully, Telegraph wrote a piece on it. And I don't know why we thought of it, or we put in a questionnaire asking whether women were interested. That's available on the web, MENO-ABC.org. And now more than 320 women have replied saying they want it. Now, the difficulty is we are still setting up the trial. So this is an important message to everybody, is that we are still setting up the trial. I have about half an hour ago clicked the button of submit to the grant application. So it has gone. The second one I'm going to do after we finish. But the first one, for the MENO-ABC trial, has just gone in as an application to NIHR's Research for Patient Benefit call. The deadline is tomorrow, but we like to submit a day before. So that has gone in, and the aim of that is this. So what we know, if you want me to say what we think, in briefly what we know.
Well, do you know what? I'm just thinking this is quite a pinch me moment because this is almost a very monumental day in the
Right.
history of cancer survivors, especially breast cancer survivors, because what I always say is we are so desperate to have more research, to have more people like yourselves working on fighting our corner, whatever the options are that we talk about, whether they're hormonal or non-hormonal. And the fact that you've today pressed publish on your application is absolutely amazing. And I feel very privileged to be here on this day with you. So thank you for sharing that with us. It's amazing.
Submitted to NIHR, not published, but yes, it's submitted. So,
Yeah.
so they will look at it and then so on and so forth. Now, it comes from two randomized trials. There are many, many studies trying to see how using HRT in women who have had breast cancer has an impact. So, in short, menopause care in women who have had breast cancer is complex. The two randomized trials have tested this. They were recruited more than 20 years ago. They're called HABITS and the Stockholm trial. And those trials were stopped early because the Data Monitoring Committee, which is the group of people who have the privilege of looking at the data before anybody else does, and they decide whether it is safe to continue the trial recruitment or not. And what they looked at, both trials, the two Data Monitoring Committees got together. And the two trials together, they found that actually breast cancer relapse, as they called it, was higher if you took HRT. If these were controlled trials, so half the people got HRT, half didn't get it. And these were any patient with breast cancer who had menopausal symptoms. And half the people got, half the people didn't get. They found that the chance of getting cancer coming back was higher, but coming back is the wrong word. It was called relapse, was higher if you took HRT. And they said, oh, this is not good enough. This is good. We have got a result already without waiting longer time. They said, we'll stop the trial. We won't recruit anymore. And we'll tell everybody, this is the result. And that is really the best evidence we have until now. And there are many, many problems with those results. And so the problems start with one is that the relapse, which they call relapse, included 3 different types of relapses. One was cancer coming back in the other breast. It's not cancer coming back, it's a new cancer in the other breast. Second was a cancer in the same breast. And third was distant recurrence. Now, distant relapse is the one which can be life-threatening. And in those days, it was incurable, and there were no drugs which could improve survival if you had distant relapse. Now what has happened is even for distant relapse, we have drugs and treatments which can actually improve survival. It is still incurable, but it can improve survival. Now, what was the proportion of these 3 types of increases because of HRT? You would say if there was a 6% increase, for example, in a person with a moderate risk breast cancer, so from 14% chance of relapse at 7 years, at 5 years, say, if it increased to 20%, that's a 6% increase. Of that 6%, more than 4.5% was from new cancer in the other breast, which are eminently treatable and usually in a good way with a good prognosis. 1.5% was from a cancer in the same breast, which is again treatable by doing an operation and is generally not indicative of bad prognosis. But the distant relapse was 0.4 to 0.5%. 0.5% increase was because of distant relapse, which today has got better outcomes. So this is one. So that means that it is not so much life-threatening to take HRT. And on the other hand, even with moderate risk disease, if you say the chance of getting relapse, including most of the good relapses, is 20%, that means 80% don't get a relapse. And if those who have symptoms, if HRT gives you relief, then the relief is in 100%. So that is not a bad balance. Other things have changed is that breast cancer today is diagnosed earlier. Outcome is better. So the numbers are proportionately smaller and smaller. So instead of 0.5, it becomes 0.1. It almost becomes irrelevant if your prognosis is better. And finally, HRT has changed. And maybe, Sarah, you can tell us how HRT has changed and how that can make an impact, because we don't know how the new HRT has an impact. It may be safer from the data that we know, but we don't know for sure. And this is what Sarah is going to tell. Is that okay, Sarah?
Yeah, sure. So Professor Vaidya is obviously talking about specifically estrogen receptor positive breast cancer. And as you've already said, currently HRT is contraindicated after all types of breast cancer, actually, according to the NICE guideline. But the risks will vary significantly depending on the type of breast cancer you've had. So the risk for DCIS is not the same as estrogen receptor negative, it's not the same as estrogen receptor positive, and even among women with estrogen receptor positive disease, the risk by use of HRT will vary considerably depending on the type of cancer that they had in the first place. So part of the equation is looking at the type of breast cancer, and Professor Vaidya has already said, if the expected benefit to you from having estrogen taken away, either by using tamoxifen or an aromatase inhibitor, if the expected benefit is small, then the risk by use of HRT is probably also small. And if the benefit to you is quite large because you've had a high-risk breast cancer, then again, if you choose to take HRT after your breast cancer diagnosis, the risk is likely to be much greater. So the consensus statement is very much about tailoring the advice and the information that we give to women according to the type of breast cancer that they've had. And the other thing to consider is the type of HRT has also changed nowadays. So we know that in women who don't have a history of breast cancer, there's a very small increase in breast cancer risk in women who use the more old-fashioned HRT regimens. So women using synthetic progestogens, the risk is something like 1 additional case of breast cancer per 1,000 women per year. But in women who've had breast cancer, the risk is very different, because if you've had an estrogen receptor positive breast cancer, then your risk of relapse will be greater. But the studies that Professor Vaidya was talking about, the Stockholm study and Habits, they used the types of HRT, those studies started in the 1990s. They recruited people back in the 1990s and they finished in the early noughties. And so women were given the old-fashioned HRT formulation. So this was oral conjugated equine estrogen, which is Premarin, and the synthetic progestogen. And nowadays we don't use those hormones anymore. If you've got residual estrogen receptor positive disease, then even body identical estradiol is likely to increase the risk of relapse based on what we know from all the breast cancer treatment trials. But the risks may not be as great as they were in those early trials, the Habits and the Stockholm study, because when we use combined HRT now, we use body identical progesterone. And in observational studies, body identical progesterone has not been shown to increase the risk of breast cancer. It doesn't appear to increase breast cancer risk. So what I'm trying to say is, I think the risk, if you take HRT, even if you're taking the best body identical HRT after breast cancer, there is still likely to be an increase in risk of relapse if you've had estrogen receptor positive breast cancer and you're within 5 to 10 years of diagnosis. But possibly the risks are lower than they were 20 odd years ago when they used the old-fashioned types of HRT. So women are presenting earlier, HRT is better. We need more up-to-date information about outcomes in women who choose to use HRT when they've been recently diagnosed with breast cancer, in 2025. That's what the MENO-ABC is about.
Yeah. So currently everyone is lumped into one group, right? Currently it's you've had breast cancer, you've got menopausal symptoms. Some of our breast cancer treatment makes us extra menopausal. We always talk about menopause on steroids for those on endocrine therapy. So the purpose of those drugs is to suppress every estrogen. So it's kind of like common logic that you then don't want to put it back in, right? For a lot of people. And for many people, any risk is too much to consider. However, we do know some people are curious, their quality of life is very much impacted. They feel they're worried about their long-term health as well. And so for some people, it's also about their long-term health and they want to consider HRT. Everyone's got different reasons. Now, when we talk about the old studies you've just mentioned, we know they're old, they're over 20 years old. We know they've used different HRT preparations. We know they've been done on very few women. So we're talking about a few hundred women, right? And we also know the trial has been closed early. So it's not very helpful for any of us. If I think I've had a triple negative breast cancer, what do those old trials mean for me? Or someone listening thinking I've had DCIS, stage 1, grade 1, what does this mean for me? And someone with an ERPR8 breast cancer might think, well, what does it mean for me? What's the purpose of your paper to try and differentiate a little bit between the different cancers as well? Professor Vaidya, maybe?
So the important thing we have to realize is that while giving estrogen to someone who might have estrogen receptor positive cells circulating in the blood because they had estrogen receptor positive breast cancer is definitely more likely to increase the chance of relapse, distant relapse. But that is distant relapse. As I said earlier, most of the risk comes from new cancers. So the new cancer in the other breast will go up irrespective of whether the primary cancer, the first cancer, was ER negative or not. Whether it was ER positive, ER negative, whatever type it was, and whatever the risk it was, the chance of a new cancer is unlikely to be different in terms of if that is the most of the risk. What we don't know is what is that risk with the new types of estrogen and progesterone, which do not go through the liver, they go directly from skin into the blood. And they may be, their pharmacokinetics are different. They may not increase the risk of stroke and cardiovascular problems. So they may actually be different risk. We don't know how much that is, but it is likely to be a new breast cancer developing in the other breast is likely to be agnostic to what the first cancer was. We don't know that for sure, but it's likely to be because it's a new cancer after all. And we know that whatever estrogen it's like giving estrogen to people without breast cancer, but who have a background higher risk of developing breast cancer. That is a definition of someone who has had breast cancer. So therefore, it is a new breast cancer that will develop. The new one is likely to become ER positive. That's what is likely. We don't know that from the two trials. We don't know what they were. So we don't have those details. And there were a large number of patients, actually, 700 patients. So it's not a small number of patients. I don't think we'll need that many more patients. We need 1,000 patients in the trial when we do the trial. So I think it is important to recognize that even someone with triple negative breast cancer, the risk from HRT, if it is new breast cancer in the other side, it may not be too different. What definitely is unlikely to happen is for them to get a relapse in metastatic disease from giving estrogen if they've had triple negative breast cancer. That risk may be not anyway increased, but doesn't seem to form a large proportion of the risk that HRT increase. You see, this is the point that I think important to remember. I think that's the reason why we will include everybody in the trial. We'll record what type of breast cancer they have, and we will be able to calculate what their risk of getting a relapse, distant relapse is from their risk. But essentially, if that is within their tolerance level, and if their quality of life is impairment is higher than that, then people, I think if they're about equal, then we will need to have what is called as equipoise. Now, this is the important point I want to explain. Equipoise is a, a status in the mind of the patient and the doctor together that their preference for taking HRT and not taking HRT is equal. And in order to do a randomized clinical trial in which half the patients get one treatment, half the patient get the other treatment, that means you need to have equal preference for the two. If the doctor or the patient has preference to one compared to the other, then you cannot do randomization ethically and morally. It's tossing a coin. I'll tell you an example. Long ago, 1970s, before 1970, 1960s and 70s, people didn't know whether doing a lumpectomy was safe or not. How did we find out? People were randomly allocated to have a lumpectomy or a mastectomy. So people didn't have, they were people who had equal preference for mastectomy or lumpectomy. Clearly, people would have more preference for lumpectomy, right? Now we know. But lumpectomy was not thought to be safe. So there was a balance. And then balance was equal. Therefore, enough patients agreed to be randomly allocated by a toss of a coin, whether they will have a mastectomy or lumpectomy. And only after those trials were followed up, we found that they did equal in terms of their survival. We can say, okay, lumpectomy is safe to do. In the same way, all chemotherapy drugs, tamoxifen, all the drugs that we do, and those trials were 20 years old, that doesn't mean they were old, because we give treatment to breast cancer patients in trials who were 30 years old, 50 years old. So those trials were done by giving chemotherapy versus giving a placebo. So because we didn't know it was effective or not and side effects were worth it or not, half people got a placebo or nothing. That same thing was done for tamoxifen. Tamoxifen was given and compared to no drug. And only when they found a difference between the two and the side effect profile was not much worse, it started as standard of care. So that's the same way we'll have to do for HRT. We'll have to give half the people the actual tablet, half the people a tablet which is blank. Because we're going to check how their symptoms change, how the effect on breast cancer is. And symptoms are so subjective, and we know that taking a blank tablet can change symptoms. That's how our mind works, right? So when you do the trial, we'll have to do that. So what this first part of our MENO-ABC application is to see how many patients out of 1,000 are ready to have an equipoise. How many people will say, well, actually, some will say my symptoms are so horrible, I must have HRT. I don't mind whatever the risk is. We expect that to be probably not a big proportion. Some people will say, I don't have any symptoms, so I don't want HRT anyway. Maybe that's going to be about that much. But we hope to have at least a proportion, 20, 30% of people who will say, well, actually, now I know the risks of taking HRT. I have symptoms, but they're a bit tolerable. But I would like to know whether I would like to get rid of them. And I'm happy to take the risk. And then we will say, okay, you have this tablet. They don't know whether it's a blank tablet or a real tablet. I will not know whether it's a real tablet or blank tablet. We will follow people up and see how it's making a difference to their quality of life and length of life. At the end of the study, we will know, we can tell people, if you take the tablet, this is going to happen. And then they can make an much more informed decision. Now, we will also include those who decide to take HRT and those who decide not to take HRT in the study and follow them up as well. We try to get those numbers smaller and smaller, at least those who are taking HRT, definitely, because at present, in any way, NICE says exceptional circumstance, right? NICE says HRT can be given only in exceptional circumstance. So if you follow the rule, there's going to be only a small proportion of patients whom we can legitimately say you can take HRT. Now, in my practice, many patients do take HRT anyway. That's with a lot of discussion, but with gray area. Now, that gray area should not be a cloud hanging on patients. What we want to do is make it sunshine, so we know that star is here, that star is here, and I'm going in that direction. That is the aim of doing the study. Maybe we'll get an answer in 5 years. If we recruit now, in 5 to 6 years' time, we should have an answer. That's me being optimistic. And I see a drop of water in the glass. I think it's full.
Well, you've already been working on this for 4 years. So what's another 5 years, right? Sarah, can I go back to your paper?
Yes.
You spoke about two processes. So there was the Delphi process and then something else that made the paper, even in the early days for you back in 2022, you couldn't imagine even going that way. What could a critique, someone that might criticize your paper, what might they say? When I see Delphi process, I'm like, has Sarah chosen all the people that approach pro HRT? Is that something people might say? Or what else are the criticisms that you may, or that people may be thinking about at home?
So that is probably the major criticism. That the consensus statement is dependent on the experts that are in the room, whose opinions you are asking. And early on, we did have slightly more menopause specialists than breast cancer specialists. So when we did the Delphi process, there were 10 GP or gynecologist menopause specialists versus 8. There were a mixture of breast oncologists and surgeons, and there was 1 breast radiologist. So we did attempt to redress that balance. So firstly, when Jay came on board after the Delphi process, that was a massive positive thing for us, because I was very familiar with the HRT studies, and I was very familiar with habits and Stockholm and so on and so forth. And I'd had a really good go at looking at the breast cancer literature, but I'm not a breast cancer specialist. And I really, really needed someone to, which is why I asked Jay, and he very kindly agreed to do it. I really needed someone who would agree to look at it, make sure I'd picked out the right studies, that I hadn't missed any key trials, that I'd interpreted them correctly, all that kind of thing. So writing the review of the evidence with Jay, Professor Vaidya, was massively helpful, and the paper would not have been this strong and robust without that, for sure. And then as the process went on, Professor Vaidya also managed to persuade some of his colleagues to become involved. So we had a sort of peer review process before we even submitted the paper to Menopause Journal. And we brought in, Jay, you could say, but it was Mike Dueck and Sasha Yuziskin and Professor Tobias. So we by the time we'd finished the entire process, it was much more evenly balanced in terms of menopause specialists and breast cancer specialists. And it really was a sort of paper of 2 halves. It was, I would say, the first half was the Delphi process, which was slightly more menopause specialist led, but the second half, I would say, was more breast cancer specialist led. And putting it all together, it felt like a good balance.
So Sarah, because in all this time, whilst you are writing this paper together as a whole team of experts, we haven't had any new evidence. So you have looked at all of the past evidence. And how have you filtered out the risk of going on HRT after breast cancer by dividing it into different breast cancer types? Because we were always lumped into this one bag. And I think that made it so difficult for us as a breast cancer survivor, navigating this, understanding what is my true unique benefit for going on HRT and what are my true unique risks of going onto this, depending on where I'm at. So how did you manage to filter down to individual cancer types?
So we've divided it into vaginal hormones, vaginal estrogen and DHEA, systemic HRT, which is regular HRT, and systemic testosterone. And then we've looked at the DCIS, the estrogen receptor negative, and the estrogen receptor positive breast cancer. And I think it's a massive strength of this paper. It's the first paper that I know of that has combined the HRT after breast cancer studies, which are not, there is some good data, but they're not that great, with the breast cancer endocrine treatment studies, which are amazing. I mean, oncologists have got huge randomized clinical trials and meta-analyses that, as menopause specialists, we didn't really know that much about before. Some of us, you know, some people certainly did, but most menopause specialists will not be familiar with those studies. So we started off with vaginal hormones, which was relatively easy. I know you've spoken about that. In fact, I've spoken about that with you before, and I know Alison Macbeth has done a really great podcast with you about that. And then, you know, I suppose on the other end, we looked at testosterone, which again wasn't that difficult because there's not much data when it comes to testosterone and breast cancer. But the bulk of it was all HRT and breast cancer. So DCIS, estrogen receptor negative, and estrogen receptor positive breast cancer.
And I think that's what makes the paper so interesting, because it could almost present a little bit of a roadmap to some other people discussing it, because we know it's happening, right? Just looking back over the last couple of years, we've had hundreds of people join our workshops, and sometimes we didn't even bring a doctor. We just wanted to give people the opportunity to talk about their fears, their worries, and their hopes. We had a lady from the Bahamas sit in her bikini join us, and she was the only one. She said we're the only group she's ever found where she was able to say she hadn't told her husband, she hadn't told her family, she had told no one, because she felt there is so much shame and worry associated with the conversation. And so just to bring it out there is great. We also know a lot of doctors really struggle with the conversation. And I wonder, it's a controversial conversation. It gets shut down a lot of times. Sometimes people are worried to have it. Professor Vaidya, what do you think your colleagues thought when you opened this conversation? It's surely not the most mainstream conversation. And does it take a little bit of a convincing of some of your colleagues, let's do this? Were you worried about some of the feedback you might get?
Right. Okay. When someone was drawing blood from my arm, my daughter was there, and they found it difficult to pierce my skin, and they said, "Oh, you've got thick skin." My daughter said, "I know that." So, so I have been challenging dogma for many years, and so I'm used to that. So therefore, in some ways, my colleagues are those who also think challenging dogma is not a bad idea. That's the only way we make progress. So, and it is not because this is a dogma that I'm challenging it, it's because I can see the trouble it is causing. So, I didn't find it difficult. And yeah, maybe I didn't know it was new. I didn't know it was different. That patients come and tell me their symptoms. It's because I asked them or whatever. At the end, they say, well, actually, nobody asked me this before. Nobody let me tell this before. And they're all details which can be perceived as difficult to discuss. And I'm not a woman. So that can also make it difficult. But I have not, I believe I have not found it difficult. So, and so I think and the colleagues whom I've discussed with, they all said yes. Now, on the contrary, when I discussed with one of my other colleagues for taking part in the MENO-ABC trial, who said to me, I've spoken to my oncologist about this, and they said they will never give HRT to their patients. They will never allow this trial to happen in their center. So that was 1 out of 6, right? So because I think I probably selected the 6 who were already on the process of. So I think it is that way. Now, so there is going to be opposition in this, and because it is obvious, it does raise. There's no doubt. There's no. It does raise of relapse. HRT will increase the risk of relapse. The question is how much.
Yeah.
How much is one ready to pay the price for the benefit of quality of life? So that's why the level of quality of life problem, the quality of life impairment, and how much improvement one can expect by taking HRT, that magnitude is all that matters with the risk. And this we take every day we cross the road, we take a flight, we think about these risks. And so this should not be separate from it. That's all we said in the paper. At the end of it, we say, let's think about it. Let's discuss it more than an outright quote unquote ban. So I believe that when people see the evidence, oncologists will be happy to take part. And we're not saying that in MENO-ABC we're going to hand out HRT. We're trying to see if how much impact it has on length and quality of life. That is what we want to study. It's a trial after all. And unless it is done within a trial, most people are happy to be participating in a clinical trial. When the trial was done, you may remember, you know what is a sentinel lymph node biopsy is. Sentinel lymph node biopsy is done in order to remove just first lymph node and to remove more lymph nodes if that first lymph node has got tumor in it under the arm. So when we found that only 1 or 2 lymph nodes, if 1 or 2 lymph nodes were involved in the sentinel node biopsy, if you remove more lymph nodes, only a quarter of people had further positive lymph nodes. Quarter, 25%. And the trial was set up in America in which patients with 1 to 2 lymph nodes were to be randomly assigned to have no further surgery versus have further surgery. Okay, now imagine that. You would know in advance because of previous data that 1 in 4 of the people whom you're not doing any further surgery will have lymph nodes left behind, which are left untreated. So people thought it was unethical to do such a trial. Many people did not take part. Yet the trial continued. It took longer to recruit. More than 700 people participated. At the end of 6 years, what were the results? People with 1 to 2 lymph nodes, this was the Z11 trial. People who had, half the people had further surgery after 1 to 2 nodes. Other half had no further surgery after 1 to 2 nodes. They must have had 25% of them must have had positive nodes. What happened at the end of 6 years? Less than 1% people had a recurrence in the axilla. Less than 1% had recurrence in the axilla.
Wow.
So just by knowing that a quarter will have positive, they don't always grow.
Wow. Yeah, because my next question was about, the often people say no one would do another trial because it's not ethical, right? Because if you know there is an increased risk of recurrence, then surely no one in their right mind would do another trial. But this explanation just is brilliant because it shows you we have to have the trial to know. You can't assume. And that was a really, yeah, that was interesting.
Even in
That was
Habits of
at the end of
Stockholm
the
study,
paper, we were convinced the ethics committee to say yes. We will give this paper to ethics committee. The grant application is in a way that ultimately the ethics committees in the country would allow us to do a trial. We can't do the trial unless the ethics board says so. So it goes through an independent ethics committee, which has patient representations, doctors, and so on. And they say, okay, well, this looks reasonable. We allow you to do it. Most breast cancer treatments are that way, giving radiation only around the tumor to the whole breast for 6 weeks. Compare those two. We got ethics approval to do it.
Yeah. Yeah, it's so interesting to hear your many examples of other trials and other studies. It really, really just is widens my horizon of how to think about it. Sarah, without the trial, because I know that will take 5 to 6 years, and I will link to the paper, of course, and I think everyone listening to this should really look at the paper themselves and spend some time. How can the paper be used at the moment? Is there anything new in the paper, and how can it give confidence to the patient or a clinician?
So I think the first thing is it's all the evidence all in one place. So patients, we paid, or UCL rather, paid for the open access charge. So everybody can access the paper, patients can read the paper, patients can download the paper, take it to their GP, take it to their oncologist and say, look, I'm not the only one. You know, people are obviously talking about this. A paper has been published talking about the importance of shared decision-making and informed choice. And we are, you know, this is definitely complex. So we are definitely not expecting or asking GPs or people who are not confident in this area to talk to women about the risks and benefits of HRT after breast cancer. That would not be fair. But all doctors need to know is that there is a case for taking HRT after breast cancer, and some women do choose to take HRT after breast cancer. And if they're really struggling with menopausal symptoms, if they've tried all the non-hormone treatment options that we would normally try first, and they're still struggling, then just refer them to somebody who does know about HRT after breast cancer so that they get to have that discussion. I had a patient recently who said that in fact, she decided to take testosterone after her breast cancer diagnosis. And she said the thing that's made her feel better is feeling back in control. And the fact that until she came to see me, she'd been shut down and, you know, sort of, and don't get me wrong, oncologists and doctors, you know, they're not shutting women down because they're really horrible people. They're shutting women down because up until now, the focus has very much been on length of life. And, you know, oncologists are trained and they're very, very good at prolonging women's length of life. And what we're saying is we're also very interested in quality of life. And for some women, depending on their quality of life, depending on their risk of recurrence, they may choose to accept a small increase in risk of recurrence in exchange for a better quality of life. And we've got to consider both length and quality of life. Length of life on its own may be all that some women are concerned with, but lots of other women are concerned about both, and some women are more concerned actually with their quality of life. So it's about recognizing that you know, these women are entitled to a discussion, and even if after that discussion they decide, actually, no, having had the chat, I'd rather not take HRT because I think that for me actually the risks do outweigh the benefits, just allowing them to have that discussion and make the decision for themselves rather than someone else sort of sitting in an ivory tower and saying, well, no, I've decided you can't have it, so sorry about that. Even that will be massively, massively helpful for women, I think.
So it's all in one place, and I think that is really helpful, isn't it? It's all of the evidence sort of summed up.
The other thing, sorry, can I just break? I forgot the original question. The other thing, I don't know if you can see this, but there's an infographic in our paper which is new, and that's based on data that we've pulled from Habits and the Stockholm study, and it's what we've been talking about and what Professor Vaidya has been talking about today. And it shows that based on that data, remember, things are probably better now with different types of HRT, etc. But if we sort of lean into Habits and the Stockholm study, illustrates very in a very easy to understand way the exact increase in risk of relapse in women if they choose to take HRT after breast cancer, and it breaks it down into the different types of relapse. So, like we said, if you've got a medium risk breast cancer, which would be about 14% risk of recurrence over the next 7 years, then HRT increases the risk of relapse from 14 to 20%. There's a 6% difference. But you can see that, first of all, that means that if all those women took HRT, 80% of them do not get a relapse. And within that, those that do, you can see that mainly it's risk of local relapse and cancer in the opposite breast, which are definitely not desirable. Nobody wants that, but they are treatable. The increase in risk of distant relapse is only, as Professor Vaidya was saying, something like 2%. It's really small. And if you've got a lower risk breast cancer, and more women today present with low risk breast cancer, then something like if all women took HRT, still 93% or 93% do not get a relapse. And most of those that do were probably going to get the relapse anyway. The increase in risk by use of HRT is even smaller. And within that, the increase in risk of distant relapse is tiny. It's about 0.2%. So these numbers are, we've been sort of throwing around a lot of numbers, and it's very difficult to understand that. But if you go away and download the paper, you can look at this information. And we really hope that patients will be able to look at the infographic and understand what we've been talking about in terms of all these different numbers, because it is very difficult.
Yes, yes. And Professor Vaidya, could we talk about testosterone for a moment? Because often
Before
when
you,
we talk,
yeah,
before we do, is there anything else you want to add to what Sarah just said?
one point is we are preparing an educational program
Yeah,
for preferably doctors and patients to help improve the counseling that can be given
yeah,
for. We're going to pull in people all over the world to try and have a series of webcasts or something of that sort to try and clarify what is known for what is happening today. Now, in addition to that, I hope within the next few months to set up the MENO-ABC study even before the grant money comes in, so that there can be registration of everybody who is considering taking HRT. So the part of not randomization, but part of people who are already on HRT or who are not on HRT, but who have had breast cancer, can register on the site to say, well, actually, I'm taking HRT. I'm just going to let you know what happens to me, both in terms of my symptoms as well as my breast cancer. So if you realize that very few proportion will get a relapse anyway, but we will find out what happens to people who are taking HRT from now onwards for the next 5 years. And then secondly, the people who are not taking HRT will know what it is in them. They are not randomly allocated. So we can only know what will happen when people choose to do these things.
yeah,
Whereas the other trial, when it comes along, we will know the randomized answer. So MENO-ABC is not just a randomized trial. It has two parts. MENO-RAN is what I call it. MENO-ABC RAN is for people who are randomly allocated. MENO-ABC registration is the people who will register to say what their symptoms are and what their status is in terms of all the health statuses. So we're hoping to set up the whole thing. We may have to do it separately, but that's the way we want to do. So the second part, the registration part, if everybody who is going to take HRT is registered in it, we will have data from all over the world. It's a big thing to dream about, but hopefully it'll get done. It needs money, and it's not usual. Funding bodies don't fund registration or registration studies because they don't always give an answer. But
yeah,
the answer we are asking for here is people who choose to take HRT, what is their chance of relapse and how much are they benefiting from HRT? So that answer we will get. We don't have a control arm. The control arm will be those who don't take the HRT, but they are not randomized. We will
yeah,
have some data, assuming that we will get randomized data. If we don't get randomized data, at least we'll have that much. See, that's the.
yeah. Yeah. And alongside the paper, which we'll link to in the show notes here, are we able to link to the MENO-ABC
Yeah, so
trial website already? Are we able to do that and for people to then find their way around it?
yeah, so where there is a Meno, if anybody types menoabc.org, menoabc.org, it takes you to one single page where we described a bit of this, and a link to a questionnaire, which is they give their name, number, and details. But we have not done anything about that yet because we were just doing the application. We will try
Yeah.
because it requires all the regulatory things to be done completely, and
Mm.
then those people who have replied in the last month. So any of you who have replied in this last month, we have not been able to do anything about it yet, but you can expect something hopefully in the next 6 months.
Yeah. And I think we're going to finish the conversation here and let you go, Professor Vaidya, because I know it's you've got a sharp finish and you've got important things to do. And maybe, Sarah, we could stay on and talk about testosterone. And so then we can give that a little bit. Before you go, Professor, what hope do you have for the next 5-6 years with the outcome of this as someone in your role who's dedicated your whole life to treating women with breast cancer and people with cancer? What are you hoping for this paper, for the ABC trial to give us?
There are some hopes and some potential dreams. So one is minimum, we will know what will happen. We will be able to tell women in a much better manner what are the benefits and what are the risks of taking HRT after breast cancer. So that will be much more granular for you. If you take this is going to happen, this is going to happen. So you can take a much more informed decision. That's the minimum we will know. But we may also know other things from this randomized trial. If HRT has other effects, which have not been elucidated until now, we might know those because they may be specific to breast cancer patients on heart, on the brain, and so on and so forth. Because patients with breast cancer have effects on the heart and the brain and lungs and so on and so forth because of the chemotherapy and radiotherapy that they have. And how that synergistically works with HRT, we don't know. It has effects on bones. We know it can reduce osteoporosis. So, and drugs given for breast cancer can reduce osteoporosis. So those interactions will be even more interesting. In addition to what biologically they would be very interesting, and it might actually make a difference to overall health of the patient. So that is that. And in general, it will be yet another move in the direction of challenging dogma. So, yeah. Okay.
Thank you so much. You've really opened my horizon with your comparisons and showing of all of these other trials and studies that have gone on. That was really, really brilliant to help us compare what you guys are doing at the moment. Thank you so much for your time today. And I'm sure I'll see you at one point, hopefully in person, at one of your events or, yeah, lovely.
Bye-bye.
Thank you so much. Bye-bye. What an incredible conversation and fantastic people to speak to. My mind is just, it feels like a little bit expanded after speaking to Professor Vaidya. I love those analogies, really. And to just think that a new clinical trial to look at the use of HRT after breast cancer is now actually happening is extraordinary. And it shows how far we've come in opening these conversations. And I have to say, I learned something new. The word Equipoise is a beautiful word. I didn't know it existed. I didn't know what it meant. Did you? It means a balance of opposing forces. And it's actually what allows a trial like this to even exist, where there's genuine uncertainty in the medical world about what the right answer is. So yes, I'll be dropping that word, equipoise, into many of my conversations going forward. It's quite a beautiful word, isn't it? So again, I'm going to link to the MENO-ABC trial in the show notes. I'm going to link to my book in the show notes so that you can read up about all of the other studies the doctors mentioned today and really get sort of up to speed with the latest or the evidence that they were talking about. And I'm going to, of course, link to their paper. And don't forget, this is just part one. Next week, I'll be joined by Dr. Sarah Glynne again for a deep dive into testosterone after breast cancer. There is a moment in that conversation that is a little bit controversial, where I don't agree or where Sarah doesn't agree, where we just don't align with our thinking, and that it's totally okay. Anyway, thank you for being here on this journey for all those many weeks. And as we've demonstrated with today's conversation, the landscape is changing and things are happening and we are never stuck. Whether we agree with this conversation of today or not, things are moving, and that can only be a good thing.